All right, today we're jumping into a condition you're absolutely going to see all the time in your clinicals, hypothyroidism. It's super common, kind of sneaky, and really, you've got to know this stuff inside and out. So let's get right into it.
So, picture this, right? You're on the floor and you've got a patient who's always bundled up, complaining they're freezing. They're sleeping half the day away, their speech is kind of slow and groggy, and they mention they've put on a few pounds. Now, these aren't just random things happening, they're textbook clues pointing straight at hypothyroidism.
So what are we really talking about here? Well, at its core, hypothyroidism is when the body just isn't pumping out enough of those crucial thyroid hormones, T3 and T4. Think of these hormones as the gas pedal for your body's engine, your metabolism. When those levels drop, it's like taking your foot off the gas. Everything, and I mean everything, just slows way down.
Okay, so to really wrap our heads around this, we got to figure out where the problem starts. What's actually causing the slowdown to begin with?
This breaks things down really nicely into the two main types. The easiest way to think about it is this. Your thyroid gland is like a factory. With primary hypothyroidism, and this is the one you'll see most often, the factory itself is busted. It's just not working right. But with central hypothyroidism, the factory is totally fine. The problem is with management, the pituitary gland or the hypothalamus up in the brain. They're not sending out the memos to tell the factory to get to work.
So let's talk about that broken factory, primary hypothyroidism. What's causing the malfunction? Well, the number one culprit is usually an autoimmune disease called Hashimoto's, where the body's own immune system gets confused and attacks the thyroid. But, it could also be from certain meds, not getting enough iodine in the diet, or even damage from things like radioactive iodine treatments or surgery.
Okay, so we've covered the why. Now let's get to the what. What are you actually going to see? As a nurse, your assessment skills are your superpower. So what are those red flags, those clues, that should make your brain scream hypothyroidism?
First off, you gotta know who's most at risk, and this is a huge one, so remember it. Females are affected 7 to 10 times more often than males. That's not a small difference. It's a massive disparity and a key piece of the puzzle right from the start.
Okay, since that metabolic engine is running on low, the effects are felt everywhere. Your patient might complain of just bone-deep fatigue, like sleeping 16 hours a day and still feeling exhausted. They'll be the one in the room asking for extra blankets even when it's warm. They might gain weight without changing their diet at all. And yeah, things like constipation, irritation, and even depression are super common too.
And then there are the physical changes you can actually see. You'll notice their skin might be really dry and flaky, and their nails are thick but brittle. A classic sign, and this is a good one for exams, is hair loss, especially on the outer third of the eyebrows. Their voice might get kind of hoarse and raspy. You might even see something called myxedema, which is this puffy, non-pitting swelling you'll see in their face, hands, and feet.
And of course, that slowdown hits the cardio and neurosystems hard. When you take their vitals, you're going to see bradycardia, a slow heart rate, and hypotension, low blood pressure. And when you talk to them, you'll notice their thinking and speech are just sluggish. This whole body slowdown really impacts everything, right down to joint pain and even their libido.
Okay, so you've done your assessment, you've connected the dots, and you're thinking, this really sounds like hypothyroidism. What's next? Well, we need to confirm it with labs. Let's decode what those results are going to look like. Now, this is where it all comes together. This is the key. In primary hypothyroidism, of course, the T3 and T4 levels are going to be low. That's the whole problem. But here's the twist. The TSH, the thyroid-stimulating hormone, is going to be high. And why is that? It's because the pituitary gland is screaming at the thyroid, hey, make more hormones. But the thyroid isn't listening. It's a total breakdown in that communication feedback loop. Oh, and you'll probably see high cholesterol too because, you guessed it, slow metabolism.
So, the diagnosis is confirmed. Now it's our turn to act. It's time to talk about the nursing plan, what we do, what we watch out for, and how we handle the meds.
All right, what are our priorities? First, we're monitoring those vitals closely, that slow heart rate and low blood pressure. We're also thinking about a low-calorie, high-fiber diet to help with the weight gain and constipation. That dry, flaky skin needs meticulous care. And this is a huge safety point.
Keep them warm, yes, but never use electric blankets. Their sensation might be dulled, and they could get a serious burn without even realizing it.
Okay, listen up because this is a massive safety alert. That slow metabolism means they process drugs incredibly slowly. If you give a patient with hypothyroidism a standard dose of a CNS depressant, I'm talking sedatives, opioids, their body just can't clear it. This is a recipe for respiratory depression. You have to be so careful. Those doses absolutely must be reduced. It's a huge deal.
So how do we fix this? The go-to medication is levothyroxine. It's basically a synthetic version of that T4 hormone the body is missing. And the number one thing you need to teach your patient is that this isn't a 2-week course of antibiotics. This is for life. It's a lifelong therapy.
Patient teaching is absolutely everything with this medication. You've got to hammer home these rules. 1. Take it on an empty stomach, at least 30 to 60 minutes before breakfast. This is non-negotiable for absorption. 2. Stick with one brand. Don't let them switch without talking to their provider. 3. They need to know the signs of too much hormone, like chest pain or feeling jittery, and report it immediately. And 4, we say it again, this is lifelong.
And there's more. We've got to talk about interactions. Levothyroxine can ramp up the effects of blood thinners like warfarin, which is a big deal. It can also mess with the dosing for insulin or digoxin. But maybe even more common are the things that block it from being absorbed in the first place. Stuff like fiber supplements, calcium, iron, and antacids. If they take these too close to their levothyroxine, they might as well not have taken it at all.
Okay, now we need to shift gears and talk about the absolute worst-case scenario. What happens if this goes untreated or if a patient with hypothyroidism gets really sick with something else? This is when we can see a truly life-threatening complication. We're talking about Myxedema coma. And let's be clear, this isn't just a bad day for someone with hypothyroidism. This is a full-blown medical emergency. The mortality rate is high. This is where the body's slowdown grinds to a complete and total halt. The signs are dramatic, and they're terrifying. You're looking at respiratory failure, severe hypotension. Their body temperature drops so low it's profound hypothermia, extreme bradycardia, hypoglycemia, and eventually a coma. Literally every single body system is shutting down. So what do? Our actions have to be fast and they have to be right. ABCs, always. Maintain that airway. We need to warm them up, but passively, with warm blankets. Again, no heating pads. That can cause their blood vessels to dilate too fast and lead to cardiovascular collapse. You'll be pushing IV fluids, giving glucose, and preparing to administer IV corticosteroids, all while watching their vitals like a hawk. So whether they're coming out of a crisis or just starting treatment, you need to manage their expectations. Recovery takes time. All those physical changes, the puffy face, the hair loss, the dry skin, can be really distressing. One of the best things you can do is reassure them that as their hormone levels get back to normal, most of these things will go away. And that brings us to this final thought. You've stabilized them. You've done the assessment, the interventions, maybe even pulled them back from a myxedema coma. So what is the single most important lesson you can teach them to make sure this never ever happens again? It all comes back to one thing: taking that medication every single day for the rest of their life. Your role as a teacher is every bit as important as your role as a clinician.